with many, many partners, all of which have brought their expertise around very specific content areas and have reviewed the content and are now sharing this through the AUDIT-C and with the field as a whole. So we are very much appreciate these organizations, and if you are from that organization, one of these organizations here today, thank you very much for joining us. I hope you enjoy what we're going to bring for everyone today. So I want to just give you our contact information. You are welcome to email us and let us know how we can help you, how we can perhaps connect you with other people that are doing SBIRT in your type of setting. We have a lot of relationships and all over the U.S., and to the extent that we can help network and bring you together with other people doing similar things so you can learn from each other, we welcome the opportunity to help you do that and also to answer very specific questions about your program. So we will make these slides, if they aren't already uploaded, we will certainly make these slides available to you so you have our contact information. And our website addresses are here because there are many more resources available to you in the public domain that you can go to these websites and be able to download fresh copies of the materials that we'll be referencing today, and also copies, color copies, so in case you want to use these in your work, you are welcome to download those materials from our website. And this, again, is just to recognize our collaborating partners in case you're not familiar with the acronyms. This is, as you can see, from a variety of fields, including social work and addiction, the Addiction Professionals Associations, the medical associations, addiction psychiatry, the SBIRT sites like SBIRT Colorado, nursing, and so forth. So by the end of this training, we hope that you'll be able to take the tools out later today or tomorrow and be able to effectively use these tools to screen your patients or clients for unhealthy alcohol use and drug use using brief, valid questionnaires such as the AUDIT-C and the AUDIT, which we'll talk about in detail today, the CRAFFT for adolescents, and the DAST and the ASSIST, as well as the NIDA single item screeners. We'll be covering all of these. And we certainly will, it's great to run out tomorrow and try to implement all of these things, but start with one and get comfortable with it, and practice is really what it's about. Practicing using these tools, that's really what's really required to be able to effectively use these in your practice. So start with one based on the direction that you're going in your SBIRT program. If you're focusing on adolescents, you might want to start with the CRAFFT. If you're going to be doing routine screening for alcohol with a full client load or a full patient population, start small and build your way up. So I can't stress the importance enough of at the end of the webinar. The evaluations really are extremely important for understanding how satisfied you are, what you're getting out of this, if this is valuable to you. It really helps us to bring quality training to you. So I cannot stress the importance of completing that evaluation enough. So it's just a couple of minutes, probably not even that, to take it. So if you could do that for us, we'd be certainly grateful. So we're going to talk about unhealthy drinking today really as a public health and safety issue. I mean, this is something that really applies to a broad population of from adolescents, young adults, older adults, and it is a public health issue. It's also in some of the settings that you're coming from, it's a safety issue. If you're working in an employer setting or with clients who are working in DOT, Department of Transportation, safety-sensitive positions, nuclear regulatory settings, medical settings where these are providers that are providing direct patient care. I mean, this is both not just a public health approach, but it really is an approach aimed at safety, harm reduction, and risk reduction. And I'm sure it's not a surprise to you that more than half the U.S. population over the age of 12 drinks alcohol. And we know that most Americans do so without really severe negative consequences. But what we do know is there's a very large proportion of the population that are engaging in risky use above safe guidelines, above the recommended levels, and they're leading to a variety of negative outcomes. And I'm sure you see this with the patients and the clients that you work with, whether it's related to work problems or family and relationships, emotional problems, physical health conditions, legal problems. I mean, what we know is that about 32.5 million, and that's probably the best estimate that we have right now, is engaged in risky drinking, not at the highest level of severity, but that's the proportion of the population that are really experiencing many of these negative outcomes that have really slipped under the radar screen. We've traditionally not addressed them or really not focused on them. And what SBIRT really does is bring an opportunity to identify folks in that group, as well, of course, as those who are in the higher levels of severity, but to really broaden the funnel, to really identify and case find folks who are experiencing these kinds of negative outcomes. So, well, when we think about what are the safe guidelines, the recommended low-risk guidelines that I'm talking about, and the 32.5 million people who aren't at high risk, they're the folks in the middle of this pyramid, the 20% at moderate risk, the 35% at low risk or moving into the moderate risk category. So you're talking about sort of the center of that. This is where a proportion of the population that I think I call the sweet spot of SBIRT, where we really have an opportunity to mitigate negative consequences and really identify early. And when we look at these patterns of use, we have to sort of understand, well, when you say no risk or low risk or moderate risk, what does that mean? So what we know is that there are many recommended guidelines out there to determine level of risk, and depending on what government agency or organization that you're working with, they adopted, similar but different guidelines around what is considered low risk or safe drinking. The ones that we're going to be using throughout this talk are the ones that you see on the right. So for men under the age of 65, the low-risk drinking guidelines are no more than 2 drinks per day, 14 drinks per week, or 5 on any occasion. And for women and any individual over the age of 65, so older adults, the guidelines are lower. They're no more than 1 drink per day, 7 drinks per week, and 4 drinks per occasion. And the takeaway message from this, though, is that it's not just exceeding one of those. It's the combination of how those guidelines are exceeded that really puts them into these categories. And I'm going to talk to you about that more specifically in just a minute. But an important point to make about these guidelines is that the recommended guidelines are designed not for none of those to be exceeded. It's not like you can exceed one or both. We don't want you to exceed the daily, the per week, or the per occasion limits. So hopefully that will help you to get a sense of what this sort of rule of thumb is called. I call it the 2-14-5 rule for men, and I call it the 174 for women and older adults. It's very easy to remember. It's also something you might want to use with your clients and your patients because they really like that. They can remember the low-risk guidelines being the 2-14-5. So when you're educating them on these guidelines, just say, hey, can you remember the 2-14-5 rule? And we find through the work that we're doing in our studies is that people do remember those, and it helps them. It's a way of educating them on the low-risk guidelines. So let's jump into to help you understand a little bit about what these low-risk guidelines are when we define them. So at the bottom of the pyramid, the no risk is those who never consume alcohol at all. Low risk is drinkers who never exceed the recommended daily, weekly, or per occasion limit. So none of those that I just mentioned would be exceeded. That's considered low-risk guidelines. And then moderate risk, those who regularly exceed one of the daily, weekly, or occasion limits. And this is where we're talking about the 32.5 million people, part of the 32.5 million people who are exceeding those guidelines and likely experiencing potentially some negative consequences. And then at the top, the 5%, the high risk, those are individuals who regularly exceed 2 or more of either the daily, weekly, or per occasion limits. Okay, so we know the costs are overwhelming, very expensive, and they lead to increased healthcare utilization, costs, hospital visits, ED visits, and so forth. So we won't go into a lot of detail about that. We all have seen what the costs are in terms of the economic impact. And these are really the recent estimates put out by the CDC at 223.5 million. What I think is really interesting about this, when you look at some of that research, is that what they're finding in this newest estimate is that a large proportion of this is being driven by lost productivity. So things like presenteeism, absenteeism, things of that nature. So they've been able to capture a real impact on the productivity of people. And as we know, most people in the consuming alcohol in a risky range are working people. So we are seeing that. So if you're working in the workplace or you're working as someone on a panel for a managed behavioral health care company that is serving employers, and you really are have a unique opportunity to, we hope, to make an impact on improving individuals functioning in the workplace and improve productivity and reduce absenteeism and so forth. And we also know that that the misuse, the risky use of alcohol use, is linked to about 50% of trauma visits and injury visits to ER. So if you're working in those settings, that becomes, I'm sure, is no surprise to you. So healthcare settings, and I'm going to use healthcare broadly. So this is medical, this is behavioral. It's in a variety of settings in hospitals and clinics and communities and workplaces, private practice, treatment centers. So we're going to just use this as an all-encompassing kind of phrase, healthcare settings. And they really are ideally suited for early interventions like SBIRT to prevent the third preventable cause of death. What we know is that, have learned through our work, is that few practitioners really use routine screening and brief intervention. And it's kind of surprising, given that the Institute of Medicine over 22 years ago put forth guidelines and statements recommending use of routine screening and brief intervention. But it's going from the research and the science to practice and translating that research into practice. And I hope what we're doing through this webinar and others is really helping to move what we've seen that is informed by evidence and moving it into practice, and that this webinar will help you to move screening into your practice. So who can perform screening or brief intervention and referral to treatment? Any trained health professional can perform SBIRT and routine screening, can administer the tools that we're going to talk about today. And what are the keys to success? Well, what we find across the board, it's really about listening. It's about using a non-judgmental tone and being compassionate, empathic, and really listening and helping to guide patients and clients in making the connection between alcohol and drug use and their health, or injury, or illness, or in the moment in which you're doing this. If you have the teachable moment, like in the ED or the trauma center, making the connection between their substance use and why they landed in the ED or trauma center. Or if you're working in a workplace and someone's at risk of losing their job, and it's because they've been coming into work hungover, or not coming into work, or they have productivity concerns, or they had a positive drug screen, or some sort of urine or breath analysis results. It's making the connection for them. And that's really what I think are the overarching keys to success. And so what can the health professional do is I would encourage you, if you're thinking about, haven't done this, or you have been doing it, but you want to expand your program, think about where the windows of opportunity are. Are there teachable moments that naturally occur in your setting? And maybe there are, maybe there aren't. But we usually find that there's generally a teachable moment in all the settings that we've worked in. And then think about how you make screening routine. How do you make SBIRT routine? Where do you begin to implement it? So think about, do I do clinical intakes? Could I integrate it there? Because it's routine, it's what we do. Do we take information on the phone and do some pre-screening? Can I integrate it there? Is there a triage process in place? Is there an annual physical exam? Do you routinely do health risk appraisals or health screens or online screens, or prior to discharge, before the patient or the client is released? So think about where you might be able to integrate screening routinely. And I would suggest, starting there, where you really think it's going to make the most sense within your organization. I mean, really the goal is not to disrupt practice, but to integrate it seamlessly into what you're already doing. And it may be that you're replacing something that you're doing because it may not be working really well, like around your alcohol screening process now. Maybe what you'll see today is the use of a different tool that could replace what you're currently doing. Or maybe it's adding a tool to something that you're already asking about. Just want to get you thinking as we move into talking about the tools and some of the case examples. So really, where it all begins, though, is you have to identify the drinking pattern. You have to ask. Without asking, we can't discover. We can't case find. So it really all screening begins with is effectively asking. And that's what we hope the tools will help you do, is to use a validated tool to effectively assess risk and identify what level of care someone might need. So again, this is really an introduction. And for those of you who aren't as familiar with the terminology, just gives you a 35,000-foot view of screening, SBIRT, and it stands for Screening, Brief Intervention, and Referral to Treatment and Follow-Up. And so we're focusing on screening today, but we encourage you to come back and listen to our upcoming webinars. We have a full series. We'll be talking more in depth about brief intervention, talking about the use of motivational interviewing in brief intervention. We'll be talking more about referral to treatment and follow-up. And so as part of a series, we really hope that you'll be able to pull things from these to help you create your own program, starting today with our screening. So let me just give you a sample workflow, just sort of conceptually of the screening and the brief intervention process. So we're sort of all on the same page of what we're talking about, this framework of SBIRT. We're talking about really a patient or client arriving at this healthcare setting. When I say arrive, it could be in person, it could be on the phone, maybe you telemedicine, telehealth, maybe they're arriving in a virtual environment. Basic information is gathered, and this could be demographic, it could be health insurance, it could be a variety of things that you're already doing as a part of a clinical intake or triage process. And screening, what we're talking about today, is integrated often within that process in the early stages of that initial contact. It doesn't have to be. It could actually be that you're going to do a very brief screen during the initial contact, but you're going to connect the client or the patient to the next provider in your setting, and they're going to do a full screening. So you have a couple of different options, but often there's some initial questions that are integrated like a pre-screen in this initial contact. And then you use the screening to determine whether more assessment needs to be done, whether its appropriate level of care is providing a brief intervention by someone there in you or someone in your setting, or whether a referral to treatment might be really what's most warranted, connecting to them to a more intense level of care. And so through that screening process, we talked about identifying risk. You can identify, and you'll see this when you interpret the tools themselves, the scores of the tools, determine low, moderate, high, and high risk. And different tools may just assess low, moderate, high. Some may assess, even 5 different levels of risk. But the main message here is that the screening tool guides determining the risk assessment, the level of risk, and in turn that helps you interpret the level of brief intervention or the level of intervention or level of care. And then what we hope is that there's follow-up in this SBIRT framework. So in follow-up, you may actually implement, again, your screening tool. You may want to follow up with them in 30 or 60 days, re-administering some of the tools that we're going to be talking about here. So you might be re-screening and seeing if they've been able to reduce consumption or reduce risk. So I hope that gives you a sense of just the overall framework. So SBIRT is simple, brief, and effective. And we won't go into all of the literature and background on the effectiveness of it, but what I can tell you is that if you are interested in the science behind it, I have some links that we can provide to you that link directly to 2 volumes that are dedicated to the research and the science behind SBIRT. But what I will bring your attention to is when you look at the U.S. Preventative Services Task Force and their review of that literature and their review of what we call meta-analytic studies. They are studies of all this, these studies that have been done prior to that, individual studies. And what they like to do is look across the studies to see what is gleaned from that as the most impactful or effective types of interventions and treatments. And using that review, they base their guidelines. And I'm sure you know that the U.S. Preventative Services Task Force has reviewed that literature. And as I note here, and particularly there's been an analysis of over 360 controlled trials pointing to screening and brief intervention as an effective treatment method or intervention method over other methods studied. So I would encourage you, if you're very interested in the science behind it, to get in contact with us, and we'll be glad to provide you some more information on that. What I will give you at a very high level of that is that when you look at the evidence for SBIRT and you look across the different domains of alcohol use, risky use, misuse, abuse, drug use, and tobacco use, the evidence for screening, there is sufficient evidence around screening across these 3 domains, alcohol, drugs, and tobacco. For brief intervention, there is substantive support, particularly for alcohol use and tobacco use, but a lot of the trials are still going on around brief intervention for drug use, including NIDA's demonstration projects that are currently ongoing. It's showing promise, but we're still growing the evidence. Brief treatment, it's the same situation in terms of support for alcohol and tobacco use and showing promise for drug use. And referral to treatment. Across the board, there's evidence to support the use of referral to treatment. So this just gives you some sense across the domains. And I would say also, which is not pictured here, but if you are interested in SBIRT for depression, there's a whole other arena out there that has a lot of evidence from the early days in the MacArthur Foundation and their work, and there are some others that we could point you to around the evidence for implementing SBIRT for depression. So screening. Let's jump into screening and the screening tools. And let's just make sure we're all on the same page about what we mean by screening. So what we mean by screening is really using a valid, brief, standardized questionnaire. Generally, it includes quantity, frequency of use, frequency use, consequences of use. And it can be administered in a variety of ways. Some of the tools have been really designed to be administered verbally, but there are many tools out there that have been validated in all of these different formats. And what we also know is that if you are you've been traditionally relying on face-to-face to do all of your clinical interactions, but you're moving to doing more telephonic work, what we've seen is that these tools, many of these tools have been used effectively in telephonic, and I'll give you an example of that in a little bit. What I don't mean by screening, which is also important, is what I don't mean by that is just asking somebody, do you have an alcohol problem? Or you don't drink alcohol, do you? No. So that's what we don't mean by screening. And what we also don't mean by screening is a urine drug screen positive or breathalyzer or a blood alcohol level. We're not really talking about that in this context. I usually refer to that as drug testing, but I know that sometimes the terminology is sort of different in different settings. So one of the things to keep in mind when we talk about screening is that asking about alcohol and drug use actually may be harder for you as a practitioner than it is for the patient or the client. Whatever the presenting problem is with the patient or client, most patients do expect that you're going to ask them sensitive questions, sometimes very difficult questions, about what's going on, regardless of whether they're presenting for family issues, emotional concerns, an injury. They know, and they expect that medical and behavioral health care providers are going to ask them questions. So by us routinely screening, it really, more often than not, patients and clients don't resist. It's often ourselves that we get in our own way. It's our nervousness, our uncomfortability with asking the questions. Sometimes because we're not sure what to do with the information. And that's what we're really hoping to do here with the screening today, is to help you get comfortable with the words, help you get comfortable with the tools. And in our brief intervention webinars, we want to help you get comfortable with what is that conversation. And so what I would suggest is practice. Practice with your colleague. Do it during clinical supervision. Practice on your family. But the more you do it, and you'll notice very quickly, the more you're comfortable with it, that your patients and clients will answer the questions, and they'll move forward with you and have the conversation. So something to keep in mind with these tools, because we're going to present some tools that what I call two-tiered tools. They have a pre-screen component, which is a very brief couple of items, and then they have a full screen component, which means if someone screens positive on the first couple of items, then it's warranted to administer the remaining items. So important to keep in mind that the same person doesn't have to do both pieces. It could be, if that makes sense for your setting, but they could be doing, one person can do the pre-screen, another person could do the full screen. The pre-screen could be done on paper, could be done at a kiosk, could be done over the phone, and then when the patient or client arrives, the full screen is done in person. So keep in mind there are very different, different combinations of ways to do things, and also keep in mind that whoever does the screening may not be the person who ends up doing the brief intervention. And what I want to point this out to you is because, screening brief intervention requires time, money, and resources. And we don't want to disrupt operational flow. And so what we need to find is where does it make the most sense, and where can we be efficient in the process? Because those things do have to be planned, and they have to be economically determined of where it makes the most sense. So I encourage you to think creatively about how things can be implemented. And this can be done in so many different settings, many of which I've already mentioned, and many different types of providers. And I would be shocked if there was any specific type of provider that was on this call that we could say, oh, that person couldn't do screening. I haven't run in or encountered any situation of a variety of professional types where screening couldn't be done. So all these different types of personnel can do this. Paraprofessionals, and they don't have to have advanced degrees. So that's also a really good thing to think about when you're thinking about planning and implementing the screening. So some of you may find this Parts of this are a refresher. Some may find this to be reinforcing some skills that you already know and may have forgotten, haven't used in a while. May fill a gap. You hadn't really been trained on the audit, but you were familiar with the cage. So this may really just enhance your toolbox, give you more things to choose from, and you may decide that a new tool actually accomplishes everything that your old tool was using, or you may want to pair those together. But so this really is a chance for you to think very specifically and focusing on how does screening work and what tools am I using and does it really make sense? What kind of information am I gleaning? And the biggest question I would ask is think about, does this screening tool help me identify a full range of risks? Not just those who might be likely meeting criteria, DSM criteria or ASAM criteria, but that full range of risks. Is your tool doing that? And if not, I should take a look at some of the ones that we're going to offer you today. So it all begins with asking, and the critical components are ask, be respectful, getting your client or your patient's permission to ask, to discuss alcohol and drug use, and avoid arguing or being confrontational. So, you know, avoiding confrontation is always the way to go. And I know many in different fields were trained that the confrontational approach is the way you go, but there's pretty much overwhelming evidence to suggest that it doesn't work so well. And so this whole approach is really about a non-confrontational approach and about asking permission and engaging them. So before you screen, you may just want to ask permission. And if you use motivational interviewing skills already, this is going to be second nature to you. Ask permission to ask them questions about their alcohol and drug use. So how you raise the issue of alcohol and drug use is important. It's all about the tone. It's about being engaging with them, not putting them on the spot. And here's just an example of how you might introduce it as a part of an intake or a triage or on the phone. Here's an example. I'd like to ask you several questions about your alcohol use and other substances. I ask all of my patients these questions because sometimes alcohol plays a role in the situations that lead patients to seek health care services. Sometimes alcohol becomes or is the problem or exacerbates some of the concerns that you've come in here with today. May I start? Now, what we find is most patients' clients don't refuse, but you know, they may wonder why that you are asking these questions because they've come in to talk to you about their fall or some other emotional concern or family concern. It could be even a domestic violence related issue. It could be an elder care issue. And so they'll say, well, that's not why I came in here today. So why are you asking me these questions? So what we suggest and was shown to work well in the settings that we've been working in is to say something like, well, I ask everyone about alcohol use. It helps me better understand your health and ways to promote wellness and prevent health and other problems. And generally people go, oh, okay, that's, you know, it's like it seems reasonable that a healthcare provider would be interested in their health and well-being. And it helps them know that you are asking for those reasons, because that is what the welfare and their well-being is what you have in mind. So after they consent, you can say, now I'm going to ask you some questions about your use of alcoholic beverages during the past year. Or I'm going to ask you some questions about your use of alcohol and prescription medication in the past year. So you can tweak this a little bit depending on what tools that you decide to use. So you remember in the pyramid, at the bottom of the pyramid, that 40% that doesn't consume alcohol at all. Well, we certainly don't want to burden them with asking them all these questions about substances if they never consumed alcohol or don't currently consume alcohol. So one of the things that you can do is to ask a single screening question up front before you jump in. I call this a pre-screening question. So do you sometimes drink beer, wine, or other alcoholic beverages? And if the answer is no, no further alcohol screening is necessary. If the answer is yes, you might proceed to the alcohol screening at that point, or you may hand off to someone who then would do the audit or the Audit-C. one thing that I've learned in using this approach is that sometimes practitioners say, well, I'm not sure I'm comfortable with that. How do I know for sure? And we don't know for sure whether, we don't know whether they sometimes, we have to really take them at their word. What some practitioners feel more comfortable in doing, because they have had experience with this client or the family, they know some of the history. There may be things in the chart. There may be things that they're, as a practitioner, privy of. They may have lab results, for example, that they're aware of, and markers that suggest to them that even though they've said no, they don't, that they may actually, in fact, consume alcoholic beverages. And so one of the things that some of the practitioners have done in their protocol is to, when they say, let's see, do you sometimes drink beer, wine, or other alcoholic beverages? And they say, the patient says no, the practitioner says, oh, okay, so you currently don't consume beer, wine, or other alcoholic beverages. So reflecting back to them and confirming what they say, what we've been finding is that sometimes the clients will say, well, once a year, Christmas or Super Bowl, and so in that case, we would want to proceed with asking the AUDIT-C. Now, you don't have to do that, but it's just a suggestion if you're uncomfortable with just a single standalone question, just to reflect back in a non-judgmental way. And then if they still say no, then you can move forward and with the rest of your process. Another item that you can use as a pre-screening is one that NIDA recommends, and this is going to pre-screen across alcohol, tobacco, and other drugs. So in the past year, how many times have you used the following? Alcohol, more than 4 or 5 drinks in a day for women or men. So if you're talking to a man, you'd say in the past year, how many times have you used alcohol 5 or more times? In the past year, how many times have you used tobacco products? How many times in the past year have you used prescription drugs for non-medical reasons? So you could break it up into individual questions, or you could simply present it as one question. So in the past year, how many times have you used alcohol, 5 or more drinks in a day, a tobacco product, prescription drugs for non-medical reasons, or an illegal drug? And if they say yes to that one question, then you would move forward to implement the AUDIT-C and, for example, the DAST that we'll talk about in a minute. So this is just an opportunity to pre-screen and implement that earlier in your process. So let's jump into alcohol screening tools. Okay, the AUDIT-C and the audit. So the AUDIT-C and the audit, we talked about a 2-tiered tool I mentioned a minute ago. So the AUDIT-C is the pre-screen. It's what I call the first tier of the tool. And the audit is the entire instrument, with the AUDIT-C being part of that full instrument. It's just that once you determine whether there's sufficient score to move beyond the AUDIT-C, that's when you move into the audit. So I'm going to walk you through that process. And I'm going to tell you a little bit about this tool, and we have provided you with a handout. So hopefully, I know they were sent out a couple of days ago and yesterday, and they're available for download right now on the website. Hopefully you already had a chance to print those out. But we're going to, for those who didn't have that opportunity, I'm actually going to show you screenshots if you're not able to have those in front of you. But if you are, pull out the audit, the Alcohol Use Disorder Identification Test. And this is the interview version. But you know, this could be done paper and pencil or on a kiosk or a tablet. So the top of this handout, there are 3 questions. And those 3 questions are the AUDIT-C. And the remaining questions, 4 through 10, are are also part of the audit. So together, the first 3 items, the AUDIT-C, plus those remaining 7 questions, together are called the audit. So it really is all 10 questions that are the audit. And this is detecting over the last year. So the questions are reframed over the last year. It detects hazardous and harmful use, risk for dependents. It's that tool that assesses that full range of risk, from that low risk to high risk. And that's what I really like about this tool. And it provides the opportunity to give immediate feedback to the patient or the client about their risk level. It draws on information that they've provided you on quantity and frequency and symptoms of dependence and negative consequences. And again, this is not diagnostic. This is really screening. It is identification of risk. But you will notice, if you're familiar with the DSM and other criteria, you'll notice that the items do map, the tone and the content of the items do map to those criteria. But just keep in mind, this is really about risk assessment. And what's different about this than the CAGE, which if you're familiar with the CAGE is an acronym really for the 4 items of the CAGE, cut down, annoy, I'll think of G in a minute, an eye-opener. The CAGE is really designed as, and I'm just mentioning it because I know many folks have been trained on the CAGE, and many of you may actually be using this now. The reason we don't recommend this is because it's only going to focus on those at high risk. It detects alcohol dependence, likely could map to DSM or other criteria, and it doesn't assess a full range of risk. So we recommend in the sites we work with is to replace the CAGE with the audit because it gives you the full picture. And the CAGE doesn't allow you to really identify the appropriate level of intervention because it's only focused on one end of severity, and that's what the audit allows you to do is to look at that level of risk and look at the matching level of brief intervention that's recommended for that level of risk. So using the audit with other screening tools. So the great thing about the audit is that you can use it with the DAST, the NIAAA single item drug screens, the ASSIST, all of which we're going to talk about today. And it fits with other mental health screeners, like the PHQ-9 or the PHQ-2, which is the depression screener. The 2 is the pre-screen. It's the 2 items of the PHQ-2. You can actually put together, and without, without risking invalidating the other tool, a brief screener made up of, let's say, the AUDIT-C, the first 3 items, plus the first 2 items of the DAST, which we'll show you in a minute, and then the 2 items of the PHQ-2. And so there you have, what, 3, 4, 5, 6, 7 items, and you've then fully created a pre-screen for alcohol, drugs, and depression. So that's what I really like about this tool. So I hope that gets you thinking about how you might be able to pair either what you're currently doing. If you're currently screening for depression, you have no risk of integrating this with what you're currently doing, or if you're thinking about implementing a new protocol that might look screen for all of these. So you can see there are many reasons why we recommend this. Right now, I've offered you as a handout the tool in English and Spanish. I have it in French. I have it in Japanese and Mandarin and Catalan and, I don't know, several other languages. It's available, I think, in 20-some plus languages. I have it in Chinese, several different forms, languages spoken in China. So let me know if there's something that you really need. I'd be glad to contact the World Health Organization and try to get you a copy of that. And you can see it's free and in the public domain, so you don't need to pay for it. Okay, so before we jump into the screener, and before we ask about drinking with our clients and our patients, one of the most important things that you can do up front, in addition to asking for permission, is to make sure that when you're talking to a client that they understand what you mean by a standard drink. So we have given you, and you could even you can get this from Rethinking Drinking, which we have uploaded a document for you that has a color copy of this. You can also download it from Rethinking Drinking site on NIAAA to have a nice color copy. You can laminate it, use it in front of you. Is to use it with either on the phone verbally or face-to-face visually, and make sure that you describe what you mean by a standard drink. Because there are many patients and clients that have no idea what a standard drink is. So one of the things you might say is, thank you for letting me ask you a couple of questions about your alcohol use. I appreciate that. And before we get started, I'd like to explain to you what I mean by a drink. What is a standard drink? A good example of a standard drink is a 12-ounce can of beer, 5-ounce glass of table wine, a little more than a half a cup, and then 1.5 ounces of spirits, a single jigger of gin, vodka, or whiskey. And as you can see, there are some others. So if you're a brandy drinker, you can see that 1.5 ounces of brandy. So whether you're doing that face-to-face or you're doing it over the phone, which we have done successfully over the phone, it really begins to help the client prepare themselves when you ask them quantity and frequency questions using the AUDIT-C, because they're picturing perhaps a fishbowl glass of wine, which is enormous, which could be 3, 4, 5 glasses, really standard drinks. They're picturing a different size Belgian beer, or they're picturing a mojito or, let's say, a Long Island iced tea. So we want to get them thinking so that we can get the best, have the best screen that we can, the most accurate screen that we can. This is just for your reference in case someone says, well, I really drink a bottle of wine on Saturday. Oh, okay. Well, that's about 5 standard drinks. So this is really for your reference. You could also print this out and have it available, but it helps you to just, do the conversion so that you're trying to help them identify what is the quantity and frequency at which they're consuming alcohol. So let's jump into the AUDIT-C, the quantity and frequency, which is consumption, and that's what the C is for, consumption. And this generally, they say, takes less than 1 minute, but I mean, I have not found myself that it does in some of the sites I've worked with. We have, on average, about 30 seconds to ask these 3 questions. That's been our average. But this is an average based on what you, from some of the studies, many of the studies that are out there, they're reported by the World Health Organization in their audit screening manual, which has been, internationally studied. So we would expect, though, no more than a minute. Okay. So let's take a look at these items. And you'll notice if you have your handout in front of you that I've given you some scripting. I've done that in case you decide you want to do this and it, verbally or over the phone or face-to-face. I put this version here so it would give you some scripting about how to introduce it before you jump into those 3. So it's going to prompt you to explain to them. You're going to ask them questions about their alcohol use in the past year, and it's going to prompt you to explain what you mean by a standard drink. In the version that's paper and pencil that you're just handing out on a clipboard, you wouldn't have those exact instructions up there. There are versions that you can download that are for self-administration. This is the interview version, but the items themselves are the same. So item number 1, how often do you have a drink containing alcohol? Item number 2, how many drinks containing alcohol do you have on a typical day? And item 3, how often do you have 5 or more drinks on one occasion? So you can see it's getting at the frequency, the quantity, and picking up on patterns of use around heavy use. That's item 3, and binge drinking. You're picking up on those patterns of use. So what you do is you would administer 1 item at a time, and you can have a couple of options. You can say, how often do you have a drink containing alcohol? And then pause and let them respond to you. And they'll say, oh, a couple times a month. Okay. So you would look over and see the response options, and that would align with 2 times a month, 2 to 4 times a month. So you would circle that. That corresponds to 2 points, and the 2 goes in the score column. Same thing for number 2. Same thing for number 3. Exactly the same way. You can just sort of open it up, let them respond. The other option is that you could read the response options off to them and have them select one. So many different ways to do this. One of the things, a couple things I've learned from this is that item number 2 particularly, what we see is that we ask them how many drinks, alcohol do you have in a typical day, and they'll say, oh, about a 6-pack. Okay, well, that could be problematic for you to figure out which one is it. Is it 5 or 6, or is it 7 and 9? So what we would suggest is you reflect back and say, oh, okay, so is it more like 5 or 6 or 7 to 9? Oh, well, it's probably, I don't know, 8, 9 beers. Oh, okay, so then that way you've really honed in on what's likely to be the quantity. And that would affect your pre-screening risk assessment. Okay, so you proceed through the first 3 items, and you notice I prompted you here to add that score up. So you take the points in the right-hand column and you add that score up. And the score will allow you to determine whether or not you have a positive pre-screen. So let's say that the score is 4 or more for men and 3 or more for women and older adults over the age of 65. That would be considered a positive pre-screen. And if it's positive, that would warrant you to then proceed to the remaining 7 questions. If it's negative, you would stop there. If it doesn't exceed those thresholds, you would stop. So let's assume that they screen positive. You could say, would you mind if I ask you a few more questions about your alcohol use? And then you proceed. How often during the last year have you found you were not able to stop drinking once you had started? Same kind of administration option. You can just let them free response, or you could say, is it never, less than monthly, weekly, daily, or almost daily? You proceed to number 5. How often during the last year have you failed to do what was normally expected of you because of drinking? Number 6, how often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session? Item 7, how often during the last year have you had a feeling of guilt or remorse after drinking? By the way, that is the G on the cage. And then item 8, how often during the last year have you been able to remember what happened, or unable to remember what happened the night before because of your drinking? So you'll notice that items 4 through 8 have the same response options, never, less than monthly, weekly, daily, almost daily. So once they get the hang of it the first time, usually, once they know what the response options are, if you decide to read them off, they know what they are, and they sort of pick up and move pretty easily through those questions. Again, those correspond to points from 0 to 4. You circle the answer, you put them along in that column along the right-hand side. So then you move to questions 9 and 10. Have you or someone else been injured because of your drinking? Again, you look at this, and this is slightly different response options. It's usually no or yes. And then when it's yes, they may say, oh, a couple of years ago. And so that sort of answered your question. You would assign it a 2. But if they just say yes, you might want to reflect back and say, so was that in the last year, or was that not in the last year? And that helps you determine whether the response will be a 2 or a 4. And the same thing with 10. Has a relative, friend, doctor, other healthcare worker been concerned about your drinking or suggested you cut down? Same thing. So, and just knowing this about this tool will help you get a more accurate screen and screening score. And so on the handout, excuse me, I've given you some rules of thumb for the cutoff points. So anything above an 8 is generally considered at risk. But the audit actually affords you the option to break down the risk ranges so that you really know what those risk bands are. So let me tell you a little bit more about those risk bands. So the risk bands are 0 to 7 is low risk, 8 to 19 is moderate risk or potential harms, and 20 to 40 is high risk or possible dependence. But let me point out something to you. If you have your handout and you flip over to the next page, you're going to see the Spanish version of the audit. But if you flip over once again, there you have your handy-dandy standard drink chart and a little breakdown of what those items are measuring, just what the domains are of those items we just covered. But if you flip to the last page, you're going to see a couple of options here. The one I just described to you, the 3, low, moderate, high risk, corresponds to the second box, the second table, called what I call interventions at 3 levels. Level 1, low, level 2, moderate, level 3, high. And we've learned through a lot of our work that in some settings, a score of 8 to 19, their protocol is not going to be any different. They're going to provide brief intervention at the same level to all of those who are at risk. But there are other settings which follow the original World Health Organization guidelines, which is the first box at the top of the page. The risk bands of 0 to 7, which are the same as the one I just mentioned, which is equivalent to what we call low risk. But here's where moderate risk, the level 2, gets broken down. The World Health Organization's original protocol is to break it down 8 to 15 and 16 to 19 rather than collapse them. And the difference is that for those who adopt this kind of intervention protocol, you'll look over at the level of intervention and you notice the level of intervention is different. So for those who are scoring at 8 to 15, they're going to get a simple advice, a low-level intervention, which is simple advice. For those who are at the 16 to 19 range, they're going to get simple advice, but they're going to get brief intervention. In some cases, using motivational interviewing and strategies towards behavior change, engaging in a variety of conversations around, let's say, the importance of making a change, their confidence in making a change, and so forth. And they may get follow-up and some continued monitoring. And then the last zone in the World Health Organization's original protocol, 20 to 40, that's the same as what I was mentioning a moment ago about the 3-level intervention. So it's really only the middle. And the practical reality of it for some settings is that they say, what we want to start with is we want to start with patients and clients who are in the 6 to 19 and higher range, that we are going to provide brief intervention with using motivational interviewing strategies, and we're going to do that really with those from that range on. There are other settings that we work with, particularly in the behavioral health and counseling and employee assistance programming side, that have said to us, we're going to provide the same level of intervention using our motivational interviewing skills with folks in the 8 to 19 range. Because in our minds, if you're at risk, you're at risk, and we feel like we could have a conversation with them about it. But there's a practical piece of time and resources, and sometimes organizations make decisions to allocate resources to this kind of protocol, the 4-level protocol, because they really don't have the time and resources to provide a brief intervention for everybody at every range. And then on the other hand, I have some settings who are providing an intervention at the appropriate level for all ranges. So just something important for you to think about in your context. And one other point about the score is that it's really not focusing on a score, whatever the score is, 10, 20, it's not that score. It's really about the range, the risk range. So a 10 versus an 11, is that meaningfully different, or is it really about there in this range? It's more about the range. And I would say, too, is that you have all this experience. You have, insight into working with patients and clients. Use your clinical judgment. I mean, for someone who is a 15, but they're experiencing emotional concerns, they're screening high on a PHQ, they have other things going on, they may have some substance use issues and so forth, you have to use your clinical judgment. Complex cases require more than just a brief intervention. And that's something that you do and know with your clients. So trust your judgment, and if they need further assessment, then that's what we would recommend. Even if it's just a simple advice here, you have to take the full patient, the full client's case into context to the extent that you're aware of those other things. If you're not aware of those other things, these are really helpful guidelines to help you determine your level of risk, a level of intervention for that level of risk. So we're not going to go into this piece right here that I see. This is a foreshadowing, I think, of what I hope will come for you, is to some of our future webinars is to really now take it to that next level. So what do you do? What does staff do? What are the elements of the brief intervention? And this is just a snapshot for you to give you a sense that each level of intervention builds on the other. So it sort of increases the intensity. And really the point is, if someone is screening at a certain level of risk, let's say low risk, you don't want to apply a hammer touch intervention to a low risk person. The same way you have a high risk individual, you wouldn't want a light touch. So when we talk in the future about brief intervention and on webinars, we're going to, I hope, help you to understand what those level of interventions are, and even give you some scripting and some protocols that really flesh out what is it that you're going to engage a person in when they screen at risk. All right. So I'm going to cover one more alcohol screening item, and then I'm going to pause and take some questions. If folks have questions, I'll take a look at that as you're typing them in. The single item alcohol screening question is another screening tool that could be used as a pre-screening tool before you administer the audit, or it could be used as a standalone screening tool. It can be used in both ways, and it's very simple. And again, that you might want to think about, do I integrate this into a clinical intake or triage process, and then do I use the AUDIT-C when the patient comes in, or with another, say there's a medical social worker or a licensed clinical social worker or a resident, would I have them do the fuller screening? So you can use these in combination. And the question is, how many times in the past year have you had X or more drinks in a day? So for men, the cutoff is 5. For women, it's 4. And so if the answer is 1, in the past year, I, as a woman, have had 4 or more drinks in a day 1 time. That's considered a positive screen or a positive pre-screen. And you could either provide brief intervention based on that you're using as a standalone tool, or you would then do, another tool, a full audit, if warranted, and then based on that score, you provide the intervention. So you have options. Okay, so while you're thinking about some of your questions, let me pause, and then I'm going to take a couple of questions, and I'm going to give you just a quick case study example at a very high level. And if it's something that relates to what you're doing and you're really interested in more details, you can certainly contact me later, and we could even talk specifically about that experience that I had. It may be that the details are really important to you. For others, it may not be specific, again, to what you're doing, but I think you can take away from it conceptually the flow, some of the lessons learned, the protocol, and so forth. So, Chris, I'm going to pause here, and I'm going to look and see if we have any questions. Okay. Are there references for the 3 levels of risk on the audit? And I can tell you that we have done 3 pilot studies that have used the 3 risk levels as opposed to the original 4. And I have pilot studies that were done in workplace settings, in a telephonic setting. And so if you are interested in learning about those studies, I could certainly send you those. What I can't say is that the World Health Organization has changed their protocols. They They have not. They have not put out a 3-level protocol. But what I can tell you is that this is something that we've been, in the real world, have had to work with, particularly in the behavioral health setting, based on their philosophy of providing interventions. I can give you an example based on that context. So I'd be glad to do that. Let's see. So I'm a chaplain, and I'm working with an older population. Is it okay for me to use SBIRT for screening and referral? And yes, in fact, in the state of Florida, the BRIGHT program is focused on screening and brief intervention and referral to treatment, working with older adult populations. And there is, I believe, sufficient evidence to support doing routine screening with older adults. There are tools that are designed specifically for older adults. So I believe one of them, and I haven't used this one myself because we use the audit with the lower cutoffs that I was mentioning, the older adult cutoffs, which are the same for women. We use the audit with them, but the GMAS, which is the geriatric mass, has been used out there as a screening tool. And I would say one of the things that we've learned in working with older adult populations is that there's another added piece to the brief intervention and reason for screening, because there's an issue around medication, contraindications of alcohol and medication, helping build awareness around the interactions. We find that that is incorporated more into the brief intervention and helping the patients understand the risks associated with that, not just with their medical, their own medical condition, but also things about motor functioning and balance and risk for injury and other things. So you may be able to learn from the BRIGHT program, B-R-I-T-E, and I would also be glad to point you to a section, and we have a curriculum that we have put together in print that has some of these materials, and there's a section in there on working with older adults. And so at the end of the presentation, if you are interested in getting a copy of that, there's a reference to that, and you can certainly email me if you want that. But there's plenty also of literature reviews out there. I have a literature review that I could send you as well if you're interested. Let's see. Okay, well, I'm going to, let's see, maybe one more. We have some of these. Some of these are just more about, so will you use, this is a good one. Will you describe the screeners, which screeners are best for using again to follow up? Well, you can re-administer the AUDIT-C. You can re-administer a single item. You can re-administer those quantity and frequency questions, again, at follow-up. You can certainly use those to look at changes in consumption over time. And the one takeaway, I can't stress this enough, is that there's no way for us to know whether our patients and clients get better unless we ask them at a follow-up. If we don't do follow-up, we don't know if they get better. So I am a huge proponent of follow-up and figuring out how to work with an organization in a very complex, busy environment to get that done, including outsourcing to do follow-up, to outsource to a telephonic service who can follow up with patients to do the AUDIT-C and do ask some of the other questions. So those are the same tools that you would use. Okay, so I'm just going to give you a quick case example of some real-world projects that we've worked on. So one of the projects that we worked on, we had 3 sites. We worked with 3 managed behavioral health care companies. We worked in their call centers, And these were clinical social workers. They were at different levels. So we had clinical social workers who were dedicated. So when a client called in, and this is, let's say the client is, it's a EAP, it's an EAP client. So this is a working adult. It's just like you or your colleague at your office space picks up and calls the phone, picks up and calls the EAP, and you get the Managed Behavioral Health Care Company's Employee Assistance Program. You have a telephonic call center. So you're calling in, there are these licensed clinical social workers, all dedicated to Company A employees when they call in. And they get 3 telephonic free sessions to talk to a licensed clinical professional. And in this particular example, what we did is we worked with employers who had 2 different models. So let's take employer A, who their employees pick up the phone, they call, they get a clinician immediately, and they're calling in about relationship problems, child care, all sorts of broad presenting problems that employee assistance programs handle. And employer B, they have a different model. Their employees call in and they get a bachelor's level professional, and that person is not trained to provide any clinical services, have a clinical conversation of any sort. They're really there to take information about where they work, why they're calling in, geographically where they are, confirming information. Sometimes they'll ask some clinical questions that are not considered only for a clinician to ask, such as, are you in danger? To do really an immediate risk assessment. Are they in danger of their own lives, or they want to really identify quickly, is this a suicide or a homicidal case, a risk assessment? And in some cases, they may actually ask about stress, some general kinds of questions. So what we did is we had a couple of models. For the clinical team who picked up the phone immediately, we call that a clinical first model. The employee calls in, they pick up, the clinician picks up the phone, and as a part of taking the normal, why they're calling in, asking about their presenting problem, engaging in them with a conversation about why they called in, where they're located, really addressing the concerns that they had, as part of their operating business, they had to integrate a routine clinical intake, regardless, even if they called in for pet care. So it was standard operating practice by the Employee Assistance Program, and they had to ask all sorts of questions that may or may not have anything to do with why the person was coming in. So they're already in this situation where they have to ask questions where the person's going to say, and why are you asking me this? Well, what we tried to do is take that opportunity where they're already asking these questions and weave in the audit screening tool. So we weaved in the full audit, starting with the AUDIT-C, and if they screened positive, then they were prompted, the clinician was prompted to ask the remaining 7 questions. And we built it right into their screen. So they're on a headset, and they're typing all this information in, and they're moving through screens, and we just built it right in to their system. And so it scored it, and then they had the wristbands, and then they knew what level of intervention. We actually trained them to use motivational interviewing strategies to actually engage them into the brief intervention. So it was very seamless. They integrated it within the current context, addressed the presenting problem first, integrated the audit tool, asked permission and had a conversation around alcohol use, made the connection between why they were screening for these things, asking them about these things, and the presenting problem, if they could. And what we found overwhelmingly in this case was that we had a 97% participation rate, very few people who called in refused. It was just that we were teaching them sort of how to be good clients and patients. We went from identification rates of less than 3% to upward of 18 to 27% by routinely screening. Get case finding, and then we had about a 78% successful referral acceptance. So connecting them specifically with someone in their region, and we would connect with them, not just that we want to refer them out about the presenting problem, but we asked them specifically to talk to this counselor they were being referred to about alcohol use. So even though that wasn't why they called in, we helped make the connection between alcohol use and having a conversation with that counselor there, or whatever service provider, primary care provider they were referred to. And so adding it in seamlessly to what they were already doing. Now, other sites actually did screen for depression, integrating the PHQ-2 with the AUDIT-C, and integrated all of that within that clinical intake. The other model was different. We had the bachelor's level person who was asking about stress and risk and so forth ask one item about alcohol use, one item about tobacco use, and they had some emotional wellness questions as well. And then based on whether that was positive, they would then hand off immediately with a warm connection, a warm transfer immediately to a clinician, and that clinician would provide the fuller screening. The biggest lesson we learned in all this is that it was overwhelming participation from the clients, that we really needed to meet our staff where they were in their stage of change. So going in and saying, you have to do this, you have to do that, here's another thing you have to do, we said, let's talk about how this will fit and make this work. And that's why we went with the two different models in different places and brought the practitioners along in their stage of change, educating and engaging them about this before asking them to do it, and then rewarding them along the way. And when we found that we encouraged through recognition that they were doing well, the screening rates were, screening completes were on target, we basically had, a lunch, a potluck kind of thing, or a recognition certificate. And that helps keep the screening, the fidelity to the screening protocol, there was more fidelity to the protocol when we did that. So, a lot of interesting experiences that I could share with you. There's just some of the takeaways and some of the different models that we use. So I'll pause and see if there are any questions about this particular example or other questions that have come up as I've been just talking about this. Let's see. What are the risks? So what are, the question is, and something that I'm sure other people are asking, and I honestly don't know the question of this, and maybe Leigh has insights, or Chris, or if not, this might be something that we can go back to our team and see what are their thoughts about answering this. What may be the risk for licensed providers who do not do their own follow-up in terms of delegating it to others? I can tell you from our experience that they're part of a clinical team that are integrated into the contract with that organization, and so it is a team approach, and in our case we have not had problems with that. That's not been an issue because it is part of the clinical team they have a contract with, and we've had that in situations where a fellow clinician will actually do the follow-up for them. But they do plant the seed when they do the screening, and they say, I would like to follow up with you, but if I'm not available to follow up with you on that day for some reason, would you mind if I had one of my colleagues here who works with me do the follow-up with you, because I really do want to know how you're doing. So I'll pause here and see, Leigh, Chris, if anybody else, if you have any insights on that.
Well, this is Leigh, and I agree, Tracy. That is the approach that I've seen taken with follow-up. That if the provider of the initial screening and the initial intervention is not available, they will, at a minimum, do some sort of a handoff and mention that a colleague will be doing the follow-up. I haven't seen follow-up provided by an outside entity in practice.
Yeah, and there are services out there that they do after-hours work and other call-based work, and they have contracts with managed behavioral health care companies. And so, you know, they are licensed professionals that do this work. And, you know, I don't know whether it's in the fine print of all the contracts or not, but I imagine when they get into a contract like that and they are outsourcing services, that has all through some vetting process. But I can't really speak to any of the sort of the legal or cross-state lines kinds of issues. But what I can say is that some are certainly have been trying to do this because it is hard to do, and they want to figure out ways to do it. There's one organization that's hired one person, and that's their job. They do follow-up because clinicians don't have the time to follow up. So, and they have like a 98% participation rate in follow-up.
I think you're speaking to the bigger issue there, that the bigger challenge is just figuring out how to work in a follow-up protocol, because I do think it is so valuable, but I think it's probably one of the biggest challenges in the overall screening and brief intervention process.
Mm-hmm. Mm-hmm.
I commend anyone who's working to figure out the best way to do follow-up.
Yeah, it's not easy, and I'd be the first one to tell you it's not easy. But if I had to decide who I'm going to follow up with, and I can't follow up with everybody that I want to, I would pick the high-risk cases, because the high-risk cases generally need longer-term support and follow-up, and there's evidence to suggest that following up with people over time in that category may have better outcomes. And some have suggested up to 2 years of follow-up for high-risk cases to help support them through that process, through recovery, through treatment, and really doing case management, focusing the resources on case management for the high-risk cases, because they're not going to be able to do follow-up with everyone. But if you want to demonstrate the value of your program, I would highly encourage you to consult with someone in your organization or a research university near you who can help you set up your own program evaluation, even if it's helping you to identify a random set of 10 or 15% of the cases that you're seeing and following up with them, and to try to demonstrate both internally what kind of impact you're having, as well as demonstrating your value and your and what's going on with your program to your stakeholders. So I think there are a couple different reasons why people follow up. I'm always in the mindset because it's good for good clinical practice for patients. But you know, we do all have stakeholders, and follow-up can be a way of collecting data to demonstrate successes and the value, and your own internal quality monitoring. Okay, so let's see, we're about at our halfway mark. So that's probably the case study that I'm gonna cover. We probably won't have another case study for my section, but what I would say, as I'm gonna show you some drug use screening tools, is that in a couple of the sites that we've worked with, you know, early on, they were a little hesitant about integrating questions about substance use. And mostly what we found is because they didn't know what to do. They'd never asked about anything like that. So they didn't know what to do. They didn't have a protocol in place. They hadn't been trained to do it. But once you give them training and give them a protocol, something that they can use to really respond to patients, and maybe it's a referral protocol, maybe it's assess and refer, maybe that's what it is. I mean, it'd be great if you're able to provide someone, a behavioralist or a resident or someone who can provide brief intervention, but if not, it's better to at least implement referral than nothing and just not assess. So even that, I think, is a good step forward, and taking a fresh look at the treatment resources around you. I find working with companies and practitioners, they haven't taken a look at their referral list in a while. So when someone does screen positive for, say, substance use, they have the same standard outdated list. And there are lots of good providers out there, and the SAMHSA has their free online and telephonic treatment locator service, and NADAC has some wonderful resources on their website about providing, finding treatment providers. So just take a fresh look. So if you're not planning to implement brief intervention for them, but you're saying, I do want to implement screening, but what do I do? Get a good solid list of referral resources and ask for outcomes. Ask the treatment providers for outcomes. Tell me about the outcomes of their programs. Take a fresh look. Okay, so I'm going to move forward here. All right, to drug use screening tools. And yet these aren't all the drug use screening tools available to you, but the ones I'm going to present are in the public domain. They're free, they're brief, they're valid, and they can be integrated pretty seamlessly from my experience if you identify the right place. And there's a growing interest, particularly around prescription drug misuse, particularly opioid pain medication. And it was that we used to ask only about illicit drug use, marijuana and cocaine and a variety. But we have really grown to and are very in tune and now really need to. It's not like, we could ask. We really are seeing a growing public health problem here, and we really do need to ask about substance use that's around prescription drugs for non-medical reasons. I mean, this is just such an opportunity and something we've generally ignored, and we can't really ignore it any longer. And you can use these items I'm going to show you, you can use in combination with the tools we're talking about today. And Leigh will be talking about a tool that gets really down into very specific substances. This tool is not designed to drill down into specific substances. So we wanted to give you this option as well as the one that Leigh is going to share with you. And it's also important to note that when most clients in the settings I work in don't come in saying, I have an alcohol problem, I have a drug problem. In most cases, presenting problems are 99% of the time something else in some of the settings I work. Now, in some of the settings, that's not the case. So that, if you're in addiction treatment setting or some other kinds of medical settings or community settings, you will have that more often than others. But really the takeaway here is that regardless of the presenting problem, just like we were talking about for alcohol use, regardless of the presenting problem, regardless of what we think is the known prevalence in the populations we're working with, or what your known identification rates, when you look at your utilization reports and you look at the cases, and despite that, really the take-home is about finding a way to routinely screen. And generally what we find is when you do that, you will identify more people. And these tools that I'm presenting now are not going to drill down to, like, if you're really in a geographic area that's focused on one particular substance as particularly problematic, or the use of, say, methamphetamines or some specific drugs, these tools aren't going to do that. But you could pair a single item drug screen with, say, the tool that Leigh is going to talk about that does drill down. So kind of keep that in mind as well. Okay, so here's the NIAAA single item drug use item. How many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? So here we're blending both illegal substances and prescription medication. You have the option of splitting these apart and making them two separate items, one about illegal drug use, one about prescription medication, non-medical use. But you don't need to. If you want to use it as a screen or a pre-screen, You ask the question. If they say one or more times, it's considered a positive screen. You could provide brief intervention, or this is where the RT, the assess and refer protocol would come in. So it's one option for you. The DAST-10 is another option, and this tool has been around for many years, and drug use in this context is really about a broadly defined use of prescription drugs for non-medical reasons or in excess of the directions. Same with over-the-counter medication. And so any non-medical use as well as illicit, illegal drug use. And this also, like the audit, is looking at use over the past year and the degree of related problems to that use. So we talked about earlier two-tiered tool. Well, here's another two-tiered tool for you. The DAST-10, which is the short version, the original is like a 28 version, but the DAST is a validated version of that original version. The first item is called the DAST pre-screener, and it's in the past 12 months, have you used drugs other than those required for medical reasons? Yes, no. If the answer is yes, it's considered a positive pre-screen, and then you administer the remaining 9 items of the DAST-10. This is where you could pair the AUDIT-C 3 items with this DAST-1 item as a pre-screen and implement that as your first level screening. So keep that in mind. The DAST-10, you have a handout. So if you have that, you can go ahead and pull that out. And compliments of Colorado SBIRT folks, and they have a nice version that you can print out on their website and that you can use verbally, or you could use it in paper and pencil. And you'll notice this version does have some instructions on it that do explain that they're asking about the last 12 months, and it does give some examples of what it means by drug use. So when someone's answering this, they'll have a sense that it's a variety of substances they're asking about. So this is the self-administered version. And it's simply a yes-no response format. So you can just tell folks, I'm going to ask you a few questions about your use of substances. You can just simply say, yes or no. And again, I would ask permission. Would you mind if I asked you a few questions about your substance use? So take a look at the items here. It's asking about drug use other than those required for medical reasons. Do you abuse more than one drug at a time? Are you always able to stop using drugs when you want to? Have you had blackouts and flashbacks as a result of drug use? Do you feel bad or guilty about your drug use? Does your spouse or parents ever complain about your involvement in drugs? Have you neglected your family because of drug use? Have you engaged in illegal activities? Do you experience withdrawal symptoms when you stop taking drugs? And have you had medical problems as a result of your drug use? So you can see there's the mapping to meeting, when you think about DSM criteria and other kinds of criteria, you can see there is some mapping to picking up on those problems and symptoms. But again, we're screening and assessing risk, not diagnosing. Each one is scored with a point, and you simply add it up. The only exception, and I've actually included this on your handout, that even though there's a score of 1 point for each question answered yes, except for question 3, and that's pointed out in your handout, in which no receives 1 point. So just sometimes we find that people just correspond a 1 to all of them, and then they add it up, and then they realize later that the score wasn't right. So on the second page of the handout, you'll notice that I've given you some risk bands to help you interpret the screening score. And so you'll see this one has multiple levels. A 0, no problems reported at this time. 1 to 2 is sort of a low level of degree of problems related to drug use. A 3 to 5 is sort of a moderate level. 6 to 8, substantial level, and 9 to 10 to severe level. And I can say in some of the organizations that we've been talking to who have been using, this, they actually they are required to use ASAM criteria. So, for a long time, they were trying to figure out, do I use ASAM criteria, do I use this or both? And the brilliant thing about this, and I can make this available to, actually we did include the reference. There's a reference already on this slide. What's brilliant about this is someone has gone through and mapped out what is the score on the DAST 10 to the recommended and the DAST 20, should you decide you want to use that one instead. You really don't need to. The DAST 10 is a validated tool. But it's mapped out the level of intervention, or what they call the action, and then the ASAM criteria, which I think is brilliant, because they really do need to document ASAM criteria in many contexts. So, all right. So I'm not going to go into another case example here, because I did give you a couple of case examples of things and sort of the things that we've been doing and how we integrated it in some of the telephonic call center settings and so forth. What I'm going to do is I'm just going to check really quickly to see if we had any burning questions, at least the ones that I can see here and answer. And let's see. Was one about, there we go, let me see if I can, somebody found that. Okay, so this is the question I found. Aside from reimbursement concerns and extra time needed for screening, what other concerns do providers have in administering the screening? Well, Leigh, I'm sure you probably have some things you could add here about, yes, reimbursement is a concern, and extra time. We have all sorts of different experiences to offer in this. Mostly, my experience is that when you get through all of the anxiety and the sometimes hostility and resistance, is that there was a fear of patients or clients not answering the questions, being perceived by their patients or clients as being rude, that they weren't really addressing the reason why they had come in, that they were just circumventing, and patients would feel disrespected, that they didn't feel equipped to respond to these issues. It wasn't part of their training, not part of what we do in our field. I mean, we've heard that. I'm a nurse. This is not part of what I do. And there are other nurses who say, well, this is absolutely part of what I do. So you really have to, that's why I say is talk to the people that you're thinking about having do this and engage them. Figure out what their concerns are. Address them. Compromise. Have that discussion up front, because if you do it in that reverse order, it makes things 10 times harder. But those are the kinds of things that we've heard along the way. Leigh, do you have anything you want to add to that?
I think that's probably the #1 concern that we hear as well. That really the anxiety and resistance on the front end of initiating this process is centered around, I don't want to offend my patient or my client, or I'm afraid that my patient or client will be upset, will feel I'm nosy, will think this is none of my business. And so my advice is always, if you are following the evidence-based practices for this, with time, these sorts of fears and concerns will be alleviated. So a lot of times it just takes a little bit of practice to realize, okay, that's not so much a concern after all. Clients and patients are generally really receptive to being asked these questions. But sometimes you just have to practice it in order to get over that barrier. And then the other piece that we do here is, this is a good idea, but it's not my job. And so that's why we really focus on promoting a team-based approach, that this can really be a part of anyone's job if appropriately trained, and that every every member of the team, let's say we're talking about a healthcare setting, a hospital, every member of the team can play a role in this process so that it doesn't have to become so time-intensive for one person. There's a shared responsibility amongst all the providers.
Those are great comments. Thank you, Leigh, very much for that. I've had the same similar kinds of experiences. With a team, we find there's and a designated champion assigned to the team. We find that most programs are more successful than those who haven't taken that approach. So that's great. And I'm going to be turning this over to Leigh, but I do want to point out in your handouts that we sent you, there is a nice card. I call it a card. What's the best word for it, Leigh? Tell me the card that gives you the nice color copy of the standard drink. So the guidelines. Yeah. What do you call that card?
We call it a pocket card.
Pocket card. So there's a pocket card for you to download and print out and color, and it has the standard drinks and visual that you can use. So I just wanted to point that out, that you have that. And also, I'm not going to go through this. This is something that Leigh may reference in her piece, but we've also provided you with what we call guideline for alcohol and substance use screening, brief intervention, or referral to treatment. And it is Colorado, SBIRT Colorado uses this guideline. It was developed with Health TeamWorks, and Health TeamWorks uses this in their trainings. It's a protocol that will help. It's an option for you that will prompt your practitioners through the process. It will walk you through, starting with brief screening. And I mentioned you could have the first three items of the audit or whatever alcohol tools you use, tobacco, drug use. You'll see in this handout that it walks the practitioner through making sure that they do screen, and that it has the individual questions here. Here are some individual questions that you could use, and it gives you the interpretations for what a positive screen is. So this is just an example we wanted to give you, so that if you don't have anything you're currently working from, this could be helpful. You are welcome to use it. It is, rightly, this is publicly available, and people can feel free to use it.
Yes, and I'll speak a bit more about it.
Terrific. Well, great. Well, I am going to turn this over to Leigh. Thank you so much. I appreciate all the wonderful questions, and for people tuning in to my section.
Well, thank you, Tracy. I always appreciate the opportunity to present and train with Tracy. You know, between our work over the past several years, we've really reached a broad audience, worked with diverse populations, diverse settings. But what's always striking to me is how similar all of the concerns and barriers are as we're working with a new setting to start this up. So a lot of the concerns that come up are similar across facilities, across populations, across provider, professional expertise. And so I encourage you to take that into consideration when you're implementing this, and look at some of the lessons that have been learned from others who've been doing this, even if their setting doesn't look just like your setting. There is a document on the SBIRT Colorado website. The website is improvinghealthcolorado.org, and it's called The Lessons Learned. And this is a nice overview that our evaluation team put together, looking at a variety of lessons that were learned implementing SBIRT in a variety of settings across the state of Colorado. So it incorporates lessons learned from urban, suburban, rural, frontier locations in a variety of clinical and community-based organizations, HIV prevention and care, employee assistance programs, school-based health centers, hospitals of a variety of sizes, federally qualified health centers. So all that is to say, I really encourage you to, if you have the opportunity and you're curious about what some of these lessons learned have been from others who've been doing this for a while, please take a look at that report. I also, since Tracy mentioned the clinical guideline that was sent to you prior to the start of this webinar, I wanted to describe that a bit more. So the SBIRT clinical guideline is a 2-page document that you are welcome to print and use. It's also on our website. The SBIRT Colorado initiative worked with an organization called Health Teamworks to develop that clinical guideline. And Health Teamworks convenes groups of committees that consist of a variety of professionals. So for the SBIRT clinical guideline work, it was a committee that consisted of psychiatrists, nurses, pharmacists, dentists, physicians, behavioral health clinicians, public health folks. It really was a wide group looking at all of the evidence around screening and brief intervention, combing through the literature and saying, what do we as a committee feel is the best practice we want to promote in Colorado? And so that is really where that clinical guideline came from. It was about a 6-month process, and it went under review in 2011. So the version that you have is the most current version of the clinical guideline recommendations. And there is an assortment of supplemental materials that go along with that guideline. There's a fetal alcohol spectrum disorder supplement. So if you have a large population of women of childbearing age, that might be a good supplement you want to look at. There's a prescription drug misuse and abuse prevention supplement that goes along, looking at that particular issue, talking about how do you educate patients about disposal, things like that. So anyway, I encourage you to take a look at all of those supplements and reach out to me if you have any questions. You can find that information on the Improving Health Colorado website, or you can go directly to healthteamworks.org. Okay, so moving forward, I am going to shift gears a bit and talk about screening adolescents. This is a common question that comes up in our trainings. At what age should patients or clients start to be screened? So really, what is the target group here? And we see a variety of facilities implementing SBIRT with a variety of age groups. So some have chosen to say, we are only going to screen our patients if they are age 18 or older. While others have said, we are going to start at age 11, or we're going to start at age 9. So we really do see sort of a wide range, and I think it varies based off of the community and setting that they're in. In Colorado, we have worked with a variety of organizations that serve adolescents and train them to provide screening using the CRAFFT screening tool that I'm going to talk you through during today's webinar. So we've worked with school nurses, school-based health centers, hospitals that serve children and adolescents, HIV clinics that serve adolescents and young adults, federally qualified health centers. So pediatric practices. So we really have seen the CRAFFT implemented in a wide variety of settings with pretty good success and a lot of good lessons learned. So the CRAFFT is a screening tool that can be used for patients under the age of 21. After I talk about the CRAFFT, I'm also going to share with you a screening tool called the ASSIST, which is the Alcohol, Smoking, and Substance Involvement Screening Test. And we see a lot of practices utilize those tools hand in hand. So they might say, we're going to implement the CRAFFT if a teen comes in who's under the age of 18, but if they're 18 and older, we're going to use the ASSIST. And we've seen others who said, okay, well, anyone who's under the age of 21 will get the CRAFFT, but if they're over 21, they will get the ASSIST, or the AUDIT, or the DAST. But again, just keep in mind that the CRAFFT has been validated for use with patients under the age of 21. It was developed by leading SBIRT experts in Boston. And you see the citation here with Dr. John Knight and his work with the Harvard Medical School. The CRAFFT has been recommended by the American Academy of Pediatrics Committee on Substance Abuse. We certainly know that alcohol and drug use is an issue amongst our adolescent populations. Alcohol continues to be the #1 issue, but we certainly see that, at least in Colorado, that marijuana use and prescription drug misuse and abuse amongst the teen population is a rapidly growing concern. Studies have shown that peak initiation for substance use amongst teens kind of generally starts during grades 7, 8, and 9, but we have anecdotally heard stories of pediatricians saying, I'm very concerned because there seems to be a trend within our community of teens starting to experiment with marijuana and alcohol at around age 8 and 9. So we definitely do encourage you, if you feel that it's appropriate, to start screening sooner. So the CRAFFT is similar to the audit that Tracy presented. It's a good way to capture who might be at risk among a teen population. And we have seen this administered in different ways. Some people choose to use a pre-screener to the CRAFFT, and the pre-screening questions would be a bit different than the brief screening you would administer to an adult client or patient. So I'll share with you some potential brief screening questions that would be more teen-friendly and would fit well with the CRAFFT. We've seen others, though, take the approach of everyone's going to get the CRAFFT. We're not going to start with a brief screen. We're just going to jump right in and screen all of our teens using the full CRAFFT screening tool. So you have a CRAFFT handout in front of you, and I just want to walk you through what the questions look like. So the CRAFFT is an acronym, and the first letter of the CRAFFT indicates, aligns with each question along the CRAFFT, if that makes sense. And in order to stick to the evidence base and, to maintain fidelity to the model, the questions need to be asked exactly as they are written. So the first question of the CRAFFT is, have you ever ridden in a car driven by someone, including yourself, who was high or had been afraid of alcohol or had been using alcohol or drugs? The second question, the R, is for relax. Do you ever use alcohol or drugs to relax, feel better about yourself, or fit in? The third question, the A, stands for alone. Do you ever use alcohol or drugs while you are by yourself or alone? The next question is forget. Do you ever forget things you did while using alcohol or drugs? And then do your friends, your family or friends ever tell you that you should cut down on your drinking or drug use? And then finally, have you ever gotten into trouble while you were using alcohol or drugs? So those are the CRAFFT screening questions. Let's talk a little bit about scoring. The rule of thumb is, with the CRAFFT, 2 positive questions, so 2 yes responses on any of those questions equals a positive screen. And if you encounter an adolescent who has a positive screen, the recommendation is then that you do a further assessment for potential drug and or alcohol addiction, looking at the DSM criteria. So for those who do score positive, that is the recommendation, that you would do a further assessment to really look at this potential addiction risk. You may find that if a teen screens positive on the CRAFFT, that they do not have an addiction and they could benefit from a brief intervention and some follow-up. But you may also find that it is most appropriate for that teen to be referred to someone who can provide the appropriate treatment. If you have a teen who has 0 yes responses, that is a wonderful opportunity to provide some positive reinforcement to that adolescent. If they score a 1, I think that is a place where you would want to offer some education and some brief advice about the risks associated with substance use to that teenager. So keep that in mind. If they don't technically fall into the positive screen category, there is still a great opportunity to offer some education and some recommendations to the adolescent about risks associated with substance use. So I mentioned that there have been some brief screen questions developed to go along with the CRAFFT. And I wanted to, I don't have them in a slide, but I wanted to review the questions with you really quickly. And these are found in the CRAFFT toolkit that you can find on our website or, again, on the Health TeamWorks website. The brief screeners are, during the past 12 months, did you drink any alcohol, more than a few sips, smoke any marijuana, or use anything else to get high? So that is a brief screen. And the anything else category includes illicit drugs, over-the-counter medications, prescription drugs, and anything else that could be sniffed or huffed. So that anything else category would probably require some probing to help explain to the teenager what you mean by have you used anything else to get high. So if an adolescent screens no to those 3 opening questions, our recommendation is that you proceed with the first question on the CRAFFT. So that they say no to those brief screen questions, but you would still ask the CAR question. So going back to the CAR question is, have you ever ridden in a car driven by someone, including yourself, who was high or had been using alcohol or drugs? Because you might have a teen who is not using themselves, but they are displaying risk by riding in a vehicle with someone who has been using alcohol or drugs. So again, a good opportunity to offer some education and a brief intervention around that type of risk. But if anyone scores yes or says yes to any of one of those 3 opening questions, we would recommend that you then initiate the full CRAFFT screening, that you would ask all of the CRAFFT questions and then proceed with scoring of the CRAFFT to determine what level of service is most appropriate for that adolescent. Really quickly here, I wanted to mention and recognize the NIAAA's Alcohol Screening and Brief Intervention for Youth, their practitioner's guide. I'm not going to go into it today, but I encourage you to utilize the link that's provided to download the guide and take a close look at it, because that might be something that you would prefer to utilize versus the CRAFFT toolkit. So it's just another option that's available to you. What I do want to take the time talking about is some of our experiences working with pediatrics clinic in Colorado around instituting the CRAFFT as a standard of care for all of their adolescent patients. So I'm going to describe a clinic that is based in more of a rural location in the state of Colorado. Again, it is a pediatrics clinic, and they have about 6,000 patients. The majority of the patients speak English, but for those who are Spanish-speaking, are native Spanish speakers, they do have bilingual providers available. So that's something that they have taken into consideration in implementing the CRAFFT. They want to make sure that they are being sensitive around and diligent about reaching all of their patient population and providing culturally appropriate services in that way. So this clinic, the clinic I'm describing for the purposes of this case study, is like I said, in a smaller community. There are about 8 providers in the clinic, and they do have an electronic health record system. They have determined that all patients starting at age 11 will be routinely screened for drug, alcohol, and depression and suicide as part of their annual health screening exams. So again, that's drugs and alcohol use, also tobacco. They routinely screen for tobacco with their adolescent population, and depression and mental health, or suicide, excuse me. So all of the patients age 11 and older are screened at an annual health exam, and the front desk staff initiates the screening process when the teen is checking in for their appointment. So they actually have handheld devices, and the teen will sit in the waiting room and will fill out the screening questionnaire, the initial brief screen first, using this handheld device. And studies have shown that teens are more likely to feel comfortable answering honestly if they are self-administering the screening question. So they will open up and share more if they are completing the screening themselves versus having someone verbally administer it. So again, that's something that you can keep in mind, and maybe you can do your own pilot testing around that. Try it both ways and see which you think is most appropriate for your population. So the handheld device is used to administer the screening, and they're using the CRAFFT for further screening around drug and alcohol use, and they're using Teen Screen for mental health. The results of the screen are documented into the electronic health record. And so then the pediatrician will review the results and determine the severity and determine the appropriate service, appropriate level of service for that youth. The provider also initiates the brief intervention, and they talk with the teen about the behavior change and about the risks associated with their use. However, if the teen is positive and the provider determines, positive on the CRAFFT, and the provider determines that a further assessment and referral is necessary, the provider will call in a co-located behavioral health specialist to talk with that screen further. So they are very intentional about facilitating a warm handoff in those situations, so that a behavioral health specialist meets the patient and can do further assessment and talk about treatment options. For patients who are who score positive, again, I think a key piece in this scenario is that these results are all documented in the chart. So the teen is screened during their annual exam, but if they come back throughout the year, there is an easy opportunity to refer back to those initial screening results and provide follow-up at that time point. And then they would start over with the full screening process at the next annual exam. So some of the lessons that have been learned out of this facility is that the clinic really feels, and the providers that have been doing this for a while now really feel like instituting this protocol of screening has helped open up the door to having conversations with their patients. They reported that previously it was very difficult to really open up the conversation around substance use with their teen patients. And this protocol, using the CRAFFT and the Teen Screen for Mental Health, has really given them a mechanism for initiating the conversation, providing appropriate feedback, and really talking about substance use with their teen patients and the family members as well. They do whatever they can to screen the patient alone. They talk to the patient about confidentiality and privacy, and but there are times when the parent is at the appointment with the patient and refuse to leave the room. And in that situation, they proceed with the screening with the understanding that maybe the teen isn't going to open up and reveal their substance use if the parent is standing in the room. Because of that, another one of the lessons that has been learned is that they have really tried to work through a protocol for if the parent is using, and if that comes up in the conversation, or if the parent reveals that they are using drugs or alcohol. And so they've really had to think through how do they manage that. And I would say that this particular clinic, they're still really sorting through what to do in those situations when the parent wants to talk about his or her substance use. In thinking of another clinic who has been implementing the CRAFFT toolkit, they actually start screening screening parents during well-child checks. So a parent brings in a younger child for a well-child visit, and that parent will be asked about tobacco, alcohol, and drug use as part of that visit. So that is an approach we've seen another clinic use. So before I move into the assist, are there any questions in particular about adolescent screening or about the CRAFFT? Okay. I'm not seeing any questions pop up on my screen, so I'm just going to proceed with the assist. Shifting gears again. You have an assist handout in front of you, so I encourage you to take that out at this point. And we are going to run through what the ASSIST screening questionnaire looks like and how it's administered, and maybe talk a little bit about why or when you might choose the ASSIST versus the audit or the DAST. So maybe we can have a little bit of a conversation or Q&A around the pros and cons of each. So the ASSIST is an acronym for the Alcohol, Smoking, and Substance Involvement Screening Test. So it is a mouthful. The ASSIST was developed in the mid to late 90s by the World Health Organization. It is an 8-item questionnaire that's been tested and validated in multiple languages in multiple countries. So if you're interested in seeing the ASSIST tool in a different language, please take a look at the World Health Organization website, and you can download the full ASSIST manual in a variety of languages. The ASSIST was developed for use in primary care, so it was meant to be a very short screening assessment that could be implemented in primary care practices, generally for patient populations age 18 and older. So most facilities that I've worked with have implemented the ASSIST starting with age 18. I have worked with a few pediatric practices who have chosen to use the full ASSIST with some of their more mature adolescents. So maybe they're 16 and 17-year-olds who seemed a bit more mature, and the ASSIST seemed more appropriate than the CRAFFT. So again, it was initially developed for use in primary care, but we've seen it in practice in a variety of settings across the country and really across the world. I have the opportunity to travel to an international conference to talk about this, and we really do see this being implemented in a variety of countries worldwide with great success. The thing that I like about the ASSIST is that it really does take a good look at alcohol, tobacco use, and a whole list of illicit drugs and prescription medications, all within those 8 questions. So it really combines all substances into one screener. And then it links very nicely to a brief intervention. So there's a health feedback component to the ASSIST tool that then guides your brief intervention in the context of health-related risks. So that's another piece that I really like about it. The one concern that I hear in the field about the ASSIST is that it cannot be self-administered. So this is not a tool that you would hand to a patient or a client and ask them to fill it out in a waiting room or in the exam room while they're waiting for the provider. This is really a tool that the evidence-based practice shows that it needs to be verbally administered by someone who's been trained to do that administration. The ASSIST screens for risky substance use, so it does a nice job of capturing different risk categories. And it determines through the scoring who falls into the low-risk category, who's moderate risk, or who's higher risk for each particular substance. And then it provides you the opportunity to start the discussion with the patient about each particular substance. So, for example, you can have a patient who is using tobacco, alcohol, and marijuana, and you will have a substance involvement score for each of those substances. And so you can incorporate that information, and they might fall into different risks for different substances, and you can incorporate all that information into your brief intervention. The ASSIST questionnaire, if you have it in front of you, you can see that It gives you some good information about substances that people have ever used, and then it narrows it down to looking at, of the substances that that person has ever used, what have they used within the last 3 months, more specifically. And then it looks at potential signs of dependency. It looks at health, social, legal, and financial consequences, so any sort of problem that that person might be experiencing related to their use. And then the final question on the assist looks at injection drug use. So I encourage you to take a good look at the introduction process. If you were going to use the assist, you would want to have a decent introduction to it before you launch into the screening questions with someone. And so in your introduction, you'd really want to talk about the purpose of the screen. You want to explain that you're going to be looking at lifetime use and use within the last 3 months. You would want to explain that you're going to be asking the person about the misuse of prescriptions. And so you would have to explain what that means. So that means using a prescription outside of the reason it was prescribed to you, or using more of a prescription that was prescribed to you. So you would want to kind of explain a little bit so that you get accurate responses on the prescription questions. There is a response card. So the assist is developed into sections, and the response card, I believe, is section B. Let me take a look real quick. Yes. So section B of the assist is the response card, and this is something that you could hand to the patient. So we have seen people build this into handheld devices, so it's being administered using an iPad. We've seen people use paper versions of it. Some people use the NIDA version of the assist that's found on the NIDA website. But most frequently, providers will laminate a few copies of this response card, and it's just something they keep in the room, and they hand it to the patient or the client, and they say, here's a response card. It will help you follow along with me as I'm administering these questions. And these are the substances I'll be asking about. And it just really helps guide the conversation more efficiently with the patient. So this is the list of substances that the patient would see on the response card. And what I'm going to walk you through are what the actual assist questions look like and how they are scored. So these are the different responses that you would guide the patient to provide. And again, you would reference them back to their response card to help keep the conversation on track. So the responses to question number 1, as you'll see, are simple yes or no. The responses to questions 2 through 5 are never, once or twice, monthly, weekly, daily, or almost daily. So you might have a patient who says, oh, I don't know, I probably use a couple times a month. So you want to guide them back to their response card and help determine which category, like Tracy mentioned earlier, and do a little bit of further probing to get clarification on really how much is that patient using. The responses to questions 6 through 8 are no, never, yes, but not in the past 3 months, or yes, in the past 3 months. So question 1 on the assist is, in your life, which of the following substances have you ever used? And again, you would remind the patient that you're not looking at medications used as they were prescribed. But you would be looking at prescriptions that are used in a way, you know, an expired prescription, something that was prescribed to someone else, taking more of a prescription than what was recommended. Those are the types of questions or considerations you're trying to get at through this screening. So again, with question 1 with lifetime use, it's simple yes or no. You would go down the list. You would say tobacco products, alcohol, marijuana, cocaine or crack, amphetamines, stimulants, and et cetera. So you would go down and just circle yes or no as you're going through. Then what you would do is you would take the responses from question 1, and you would narrow down looking at use within the last 3 months. So you would ask the patient, of the substances you reported using in your lifetime, how often have you used those substances in the past 3 months? So I'm looking at the full assist manual right now, and the question reads, in the past 3 months, how often have you used the substances you mentioned? So let's say you have a patient who said yes to lifetime use for alcohol and tobacco. So you would say, in the past 3 months, how often have you used alcohol? Or let's start with tobacco. And then you would prompt the patient to respond with never, once or twice, monthly, weekly, daily, or almost daily. And then you would move on to alcohol, monthly, or never, once or twice, monthly, weekly, and so on. So that's how you would proceed, and you would just circle on your screening tool what their response was. If the patient says never to everything on question 2, meaning they haven't used any substances within the last 3 months, then you would skip ahead to question 6. But if they say that they have used substances within the last 3 months, you would move on to question 3. And you would again narrow it down. So you want to look at, okay, so of what you're using and what you've used in the last 3 months, how often have you had a strong desire or urge to use that substance? So if the patient says, I use alcohol weekly, you would say, during the last 3 months, how often have you had a strong desire or urge to use alcohol? And again, the responses for those are never, once or twice, monthly, weekly, or daily, almost daily. Question number 3 can be tricky. So you might have patients or clients who would want you to explain what that means. What does it mean to have a strong desire or urge to use? They might say, well, I enjoy going out with my friends, but I wouldn't necessarily say that I have to have a drink. And so, again, I encourage you to use your best judgment, your clinical experience, your knowledge of that patient to really help identify which category is most appropriate in those situations. Like Tracy also mentioned earlier, it's not so much that the score needs to be precise in the end. It's that you want to capture a good sense of the range of risk that this patient might be falling into. So don't get too caught up in what the exact score should be. Should they be a 4 or a 5? Don't focus so much on those point differences, but think in terms of the overall range of risk. Question 4 is, during the past 3 months, how often has your use of the substance that they've reported using led to health, social, legal, or financial problems? So in the situation, the example I just gave with alcohol use, you would say, during the last 3 months, how often has your use of alcohol led to any health, social, legal, or financial problems? And again, they would respond never, once or twice, monthly or weekly, daily or almost daily. We also found that it's helpful to help the patient think back to 3 months ago. So it might be helpful to say, think back before the holidays. You know, that's been about 3 months, give or take. So think about what's happened in that time span. And that helps them to really think through what has happened within the last 3 months and what has their pattern been. What sort of issues have come up? Have they been late to work because they were feeling hungover? Have they had arguments with their partner or spouse? Have they been using tobacco and their child has asthma and that's led to some concerns? I mean, those are the types of issues that you're looking for with question number 4. Question 5 is, during the past 3 months, how often have you failed to do what was normally expected of you because of your use of alcohol? So I'm going to focus on alcohol because with the patient example I'm giving now, that's what you would focus on, what they have used within the last 3 months. So how often have you failed to do what was normally expected of you because of your use of alcohol? Questions 6 and 7 refer back to lifetime use. So it's helpful to really keep that in mind. When you get to questions 6 and 7, you really want a broader scope of what they have ever used in their life when you're asking these questions. So you would look back to question 1 and you would say, okay, the patient used tobacco, alcohol, and marijuana. So has a friend or relative or anyone else ever expressed concern about your use of tobacco, alcohol, and marijuana? So again, keep that in mind that 6 and 7 jumps back to lifetime use. And the response categories change. So this is where the patient would say, no, never. They've never expressed, no one's ever expressed concern. And they would say yes, but not in the past 3 months. Or yes, they have expressed concern, and that concern was expressed within the last 3 months. So those are the different, 6 and 7 are different scoring categories, or response categories. Question 7 reads, have you ever tried and failed to control, cut down, or stop using the substances reported in lifetime use? So have you ever tried and failed to control, cut down, or stop using tobacco, alcohol, and marijuana in this example? And again, no, never. Yes, in the last 3 months. Yes, but not in the last 3 months. Those are the response categories. And then question 8, have you ever used any drug by injection? No, never. Yes, in the past 3 months. Yes, but not in the past 3 months. So those are the categories for question 8. Okay. So let's talk a bit about scoring. I think in overall, when people are looking at the full assist manual, they feel a little bit overwhelmed by the paper. There are condensed versions of the assist that are referenced in the slide and that you can find on our website that really kind of shrinks down all of these questions onto one page front and back. But I think using the full assist manual is the best place to start to get comfortable with the full process and getting comfortable with the different response categories. So with scoring, it does involve a little bit of math because you will have an individual score for each substance. The big thing with scoring to remember is questions numbers 1 and 8 do not count in the final score. So this is what trips people up. When I do face-to-face trainings, we do some practicing around this, and we always practice the scoring, and people tend to forget about questions 1 and 8, and then they add them into the score, and then the patient scores much higher than what was intended I guess I should say. So remember that 1 and 8 do not count in the score. So what you would do is you would look through your screening through questions 2 through 7, and you would calculate the tobacco score. And then you would go through and you would calculate the alcohol score, and then the marijuana score. So again, you're looking at all the different substances the patient ever reported using, and coming up with an individual substance involvement score for each of those substances. There's a place, if you have a copy of the full ASSIST manual in front of you, there is a place then where you would document each individual risk score. And then the item C, so section C of the full ASSIST manual, is a feedback report card that you would hand the patient. So it's something that they could take home with them. And that is also a place where you could document each individual score. So you could say patient had a 22 for tobacco, patient was an 18 for alcohol, and an 11 for marijuana. And you would document that on the feedback report card, and you would then use that to guide your conversation with the patient. You would say, would you mind if I take a few minutes with you to share your results? And you would explain what those different scores mean. So it really does open up the conversation, the intervention seamlessly. Here are the guidelines that we follow for determining risk level using the ASSIST scoring results. So you might have a patient who is low risk for alcohol, moderate risk for marijuana, and high risk for tobacco. Because again, keep that in mind, you'll have different levels for each substance, and then you would determine where you want to spend your time with your brief intervention. Do you want to try and incorporate all substances into your intervention, or do you really want to focus on one area? So for alcohol, the screening guidelines that we follow are anyone who scores 0 to 10 for alcohol is low risk. And that patient would benefit from some positive reinforcement or maybe a little bit of education about their substance use or about their alcohol use. But in general, that would be someone, if they're in the 0 to 10 range, that's someone who's low risk. For all other substances, including marijuana and the misuse of prescriptions, you would want to consider anything in the 0 to 3 range. So the cutoff is much lower for all other substances. 0 to 3 would be considered low risk, and that's the patient who would benefit from some positive reinforcement or maybe a bit of education. For moderate risk, we prefer to divide the moderate risk category into 2 different groups. So you can be low moderate risk or you can be high moderate risk. Low moderate risk is the sweet spot that Tracy mentioned earlier. So that is really the target population for this work. You're trying to identify who falls into that category to provide the evidence-based brief intervention to help that person start to think about change, to think about cutting back or quitting. So for alcohol, that sweet spot on the ASSIST is a score of 11 to 19. For all other substances, it's a score of 4 to 19. For those who score a bit higher than that, so 20 to 26 for alcohol or other drugs, those are the patients who may need more than a brief intervention. Maybe they need a few brief interventions, or maybe they really need brief treatment or brief therapy. What we recommend is that if someone falls into this category, you try to facilitate a warm handoff to someone who's a behavioral health person that is able to provide anywhere from 1 to 6 short counseling sessions. Most commonly, that involves some solution-focused therapy or some enhanced motivational interviewing. So that's what we would consider to be brief treatment or brief therapy. Anyone who scores 27 or higher for alcohol or any other substance would be considered high risk, and that is the person that you would want to try and refer to someone who's qualified to provide a full diagnostic assessment. So again, keep this in mind. If you score 27 or higher, it doesn't mean that you are making a diagnosis of addiction. It means that person is high risk, likely to be dependent, and needs a further assessment, a diagnostic assessment. So if someone is 27 or higher for any substance, we recommend that you refer them to a licensed substance use treatment provider. In Colorado, if someone scores high in that category, and I would say almost in any category for tobacco, we recommend a referral to the Colorado Quit Line for some tobacco cessation coaching. So keep that in mind when we're talking about referrals for tobacco. It's generally to the Colorado Quit Line. So I talked a bit about the different scoring categories and what you would provide. I want to refer you back to the full assist manual in item C in the manual. Again, that's the feedback report card, and it really does link very nicely back to health-related risks associated with each particular substance. And it really does provide, for those of your patients who fall into that moderate risk category, it really does provide an opportunity to kind of offer some good education about risks attributed to each of those different substances they reported using. And I talked a bit about the feedback report card, but again, that's something that you can use to hand the patient that they could take home with them. They could read more about it after you end the intervention or if you need to leave the room. But I also, again, am referencing back to something that Tracy said at the beginning of the webinar, that anytime you are providing feedback, even when you're using this feedback report card, it's very important to ask permission. So ask for permission to share the results with your person, with the person that you're screening. That really does go a long way in terms of opening up the conversation and providing a good brief intervention. I won't spend a lot of time talking about the assist in the context of a case study. I did want to mention a hospital that we've been working with who has implemented the assist for about 1.5 years now. And so I wanted to share with you just a bit about their process. This is a level 3 trauma facility in a suburban community. And their goal is to screen all emergency department patients at Triage. So the nurses, the Triage nurses, have been trained to administer pre-screening using the AUDIT-C and the single item drug question by NIDA. They have been trained to administer those questions to all patients who enter at Triage. Those questions have been built into their electronic medical record system. So they're just radio buttons that the nurse would click as they're asking the questions. It has been built, the expectation of asking those questions has been built into the job description for the Triage nurse. And then they receive training at orientation on how to do that, how to ask those questions appropriately. If someone scores positive, then they are referred to a behavioral health tech. So this particular hospital has hired behavioral health technicians, but I would say that their behavioral health technicians almost play more of a paraprofessional role. They're not licensed clinicians, but they are trained to help have these types of conversations. They're trained to help de-escalate patients who are seeming upset. And they work hand in hand with the behavioral health team, so with the social work team. So they've all been trained to administer the assist. They will approach the patient once they move from triage into the emergency department. They will approach the patient bedside and administer the full assist and score it and provide the feedback and the brief intervention. They then document in a note in the EMR that the assist has been provided, what the risk level was, and what the goal, the patients are, through their intervention, they're establishing a goal, and they'll document what the goal is, and the provider will come into the room and reinforce the message. So they'll see in the chart what the goal, the patient identified, and the provider will reinforce that conversation and that goal. So I think some of the lessons that have come out of this is that you really do, out of their experience, is that you really do need some good champions. In this particular setting, it's the trauma team. The trauma team is really, they believe in this work, and they offer booster training around it. They talk about the value. They share the results with the others within their emergency department. They found that ongoing brief trainings and brief tips work best. So rather than explaining spending a lot of time explaining the evidence and the data and why they're doing this, they really focus on, okay, how do you do it? Here's what it is, how do you do it? And then they try and reinforce that. So it's not just a one-shot. It's not just when you're a new hire and you learn it at orientation. They do refresher quick sessions throughout the year. They have really found that for the triage nurses, the screening is short and it's not really very burdensome, but that you need administrative and leadership support and buy-in to get over those initial misperceptions and barriers that Tracy and I spoke about earlier. So you really do need someone championing this work at a leadership level to help kind of get over that hump of, this isn't my job, I'm not equipped to do this, it's none of my business. You can move through that if you have some good leadership support. And they explored with the idea of having a physician standing order and found that it really wasn't necessary. If you have appropriate policies and procedures in place, the physician order for this particular case example wasn't necessary. So that is what I wanted to share with you about the assist, and I see that we are coming to the end of our time. So I'm going to stop here and see if there are any questions at this point.
Leigh?
Yes.
Could you just, we have a couple of questions about the age range for the CRAFFT and assist. Can you just reiterate the age ranges you were talking about a minute ago?
Oh, sure. Thank you. And I should say, Tracy, I'm not seeing questions on my screen, so if you see others, please let me know.
Yeah, I'll field them. No problem.
Thank you. So again, with the assist and the CRAFFT. With the CRAFFT, it's been validated for youth age 14 to 21. We see it mostly, I would say, my experience has been in practice with age 11 to 18 in general. With the assist, the recommendation is to use the assist with those 18 and older. So I would say that is what we promote, and that's what we see happening in healthcare facilities in Colorado. So if they are using the assist, they're using it with their patients age 18 and older. If they have patients under the age 18, they are using the CRAFFT in those situations.
And Leigh, do you know if the assist and the CRAFFT have been used in all states as part of some routine practice. I don't know if this person is specifically talking about like mandates to use the assist or CRAFFT.
I would say, so I have colleagues in other states who are using the assist in CRAFFT. But in terms of mandates, the only thing that would come close to a mandate from my perspective are when the state Medicaid plan says, in order to bill the SBIRT codes under Medicaid, you need to use this particular screening tool. So we have seen some states indicate in their Medicaid state plan that for SBIRT reimbursement, certain tools need to be used. And that's not the case in every state because, again, it's those decisions are made on an individual state level. But that might be something you would want to look at your own state Medicaid plan. You'd want to see, are the SBIRT codes activated for Medicaid reimbursement? If they are activated, what are the requirements to bill those codes?
Yeah, that's been my experience. Is it really is a state-by-state thing. If it's if it's turned on, then they may have specific requirements. There are some states that are working on this, and they're using the audit screening tool. So really checking locally makes the most sense, I think. And we are trying to learn more and more about who's doing what and using what in what states, and to the extent that we're able to track this in the coming months, we hope to be able to do that. So we always appreciate that question, because in a future webinar we may actually be able to answer specifically about some states in the future. Just right now, I'm not sure that it's crystal clear yet. And there's a questions about the codes. I could share one summary slide, and I can get that loaded up to the website. It'll have the G codes, the H codes, all of the codes currently approved for the private insurance, as well as non-private, government-based insurance. So I'll get that slide to Chris and have Chris upload that. And I would also say, for those, I can see there are a number of questions around billing and reimbursement and interest in that. Not one that I think that we could probably go into any depth on in this call. Overall, it really is about understanding what is turned on in your state and making sure that you understand who in that state can use those codes. And I'll give you an example that in one state we were working with, their understanding was that the codes had been turned on, that private insurance would be paying for them, that the Medicare, Medicaid codes would be paid on, but their interpretation was that the definition was that only physicians working with Medicare, Medicaid patients would be able to use them in that state. So what we find is there's a lot of conversation and probably a lot more ambiguity than clarity in some states, but certainly go and ask. What the insurance providers tell us is that they'll pay on them, that we will pay on them, but it really does come down to the state. And I would also say, if you're really interested in this topic further, I'm going to show you a link here. I believe I don't know if I have control over the slides or not. Let's see. If not, maybe Leigh, you could advance the slide. Okay, here we go. So you see a link here. It says Learn More and Connect. So the big initiative, which is the Brief Intervention Group, and who is sponsoring this really along with the ATTC. The big initiative is part of the ATTC, the National SBIRT ATTC. And so we are really a team. And the resources that we have under the big initiative which is, we have 2 groups, and they have a lot of resources available, particularly under the reimbursement and billing area, under the hospital sbirt.webs.com link that you see here. That website has a number of free materials, articles, education, archived recordings on these and a lot of other topics that you are more than welcome to access at any time. And the other one, big sbirteducation.webs.com, is broader in terms of it's focusing more around broadly behavioral health practitioners, employee assistance programs, counseling, addiction. That kind of practitioner often gravitates to that particular website. And that also has information on billing and reimbursement and lots of other resources that are freely available to you. And I don't know at this point whether what the extent of information is available on the National SBIRT ATTC website. I don't know it off the top of my head, but I do imagine that if we have materials related to this topic, that we could provide a link to that on the page where there are these handouts that we've been talking about today. So very hot topic.
Yeah, this is Chris. Just so everybody knows, if they go to our webinar site on March 20th, we are going to be having a 3-hour webinar on reimbursement and coding for clinics, health systems, and hospitals.
Wonderful. Thank you, Chris. I think, and the speaker for that is really incredibly knowledgeable and intimately familiar and set up the system in Oregon using the EPIC software system. It really is a really knowledgeable person. I would encourage you to attend that and share that with your colleagues who are really interested in that topic. Let's see. We have about 2 more minutes. And you want me to see if there's another burning question here that we can, any other burning questions? Let me ask you, Chris, is the PDF of the PowerPoint, will that be loaded after the webinar?
From what I understand, I would be able to send them out in a handout format.
Sure.
That's the way you want them distributed?
Yes, we can send them out as an email attachment, as a PDF document for you. I can also make that PDF document a document you can load onto the website. We have an agreement among the organizations that we can provide a PDF. We don't provide them in this raw format because of potential editing and so forth, but we will provide them in a PDF format.
Yeah, and I can certainly do that here. You don't have to send me anything. That's the way we always send them out after webinars.
Right.
So we will have those available. And what I was going to do, and I have emailed some people who have questions, is that by tomorrow noon, and hopefully even by the end of the day today, I will have the recorded webinar and the PowerPoints in a PDF format in the IRETA webinar library, and I will send everybody the link to that. So they'll be able to go in, view the whole webinar again if they want to, and also have access to the PowerPoint.
Terrific. Thanks, Chris. Well, Leigh, anything you wanted to add, or any other things that came to mind you really wanted to mention before we wrap up?
I just want to say thank you for everyone for staying with us throughout this. It's so important to talk about screening because we really need to work on getting validated, tested screening tools in place to kind of steer away from the questions that too long we have heard, like, do you think you have a drinking problem? So I thank you for spending 3 hours with us as we presented several options that are available on the public domain. If you have any questions, please don't hesitate to contact either one of us.
Great, thank you, Leigh, and I obviously feel the same way. And So I'll just, we'll go ahead and close, and we'll try to address, any other questions we can. You can certainly email me your question if it didn't get answered. And just to remind you, again, the evaluation form is really critical to us and to our project, and for us to make our targets of really reaching you with quality training. So please complete that when you get that following this. When does that come out, Chris? Is it immediately or within 24 hours?
I think it takes the system about an hour or so to get the reports on the attendees versus those who just registered. So it'll get to everybody this afternoon.
Terrific. Wonderful. Well, thank you.
And I'll be sending out 2 reminders also. So if they don't see it today, they can certainly have some other chances to do that. But we do appreciate your participation in this, Tracy and Leigh. We really appreciate all the knowledge that you've given us today. And we also want to thank all the attendees. We've had 200 people on the webinar today, which is a nice size audience, and we appreciate all your time.
Thank you. We appreciate being invited. Thank you so much.
Okay, well, thank you, everybody. We'll close the webinar now and look for our email and emails from me also with links to the materials. Thank you, everybody. Bye.
Bye.